So as mentioned, I will be following what Dr. Paolo talked about. So he addressed Acalabrutinib in first line. I will be talking about Acalabrutinib, the second generation BTK inhibitor in the relapsed refractory setting, taking advantage of the ASCEND study, which is the pivotal study that led also to the approval of Acalabrutinib in many countries around the world. For some reason here we go. So I start with a couple of clinical cases. I go quickly also to gain some time, because this is a young gentleman with not so many comorbidities expected due to the age. He has been treated with FCR as correctly, because he was young, a little bit above 50 years of age, when the disease progressed and needed therapy with bulky lymph nodes more than 10 centimeters in size. This person was not treated by us, but in another hospital, so they didn't do any workup, genetic workup at that time. The patient progressed 5 years later, so when he was 50 years of age, and in May 2015, he had again progressive disease due to enlarged abdominal bulky lymph nodes. At that time, we did genetic workup. The patient had a sort of intermediate FISH profile with deletion 11q, mutated in the immunoglobulin genes, unmutated in the immunoglobulin genes, and he had also a mutation in the p53 gene. Very likely, maybe it was present even before starting FCR, but maybe instead it has been selected later on. Having said that, the patient received Acalabrutinib within a clinical trial. At that time, we didn't have ASCEND studies yet open. This was a previous study. As you can see, the bulky mass in the abdomen, and then a blood cell count which was fairly okay, no anemia, no thrombocytopenia, and so the main reason was this recurring lymphadenopathy. After 2 months of Acalabrutinib, 100 milligrams 2 times a day, this is the effect. We are somehow not surprised. We know how the BTK inhibitors are very well, very effective drugs in CLL, and Acalabrutinib is no less, as you can see very nicely. So, and again, I mean, he recovered also 1 gram of hemoglobin, but this was not really his major problem. So, as already alluded to by Dr. Paolo, the drug is also well tolerated, and this patient had suffered only from a pneumonia that actually was a pneumonia that we treated off hospital, so he didn't need to be hospitalized. And as it always happens when the patient has only a mild clinical picture, we keep the Acalabrutinib going on, so we don't stop, we don't discontinue the treatment. We give the antibiotics, in this case levofloxacin, and then everything resolves, and the patient did not complain about much else. 5 years later, he is still in partial response, as we expect in the relapsed refractory setting with a BTK inhibitor. The abdominal lymph nodes are below 2 centimeters, and as you can see, the blood cell count is even better than before, so he has more than 16 grams of hemoglobin, and platelets absolutely fine. So the second case is another young man with a little bit more strange story, because he was already retired at that time, and he underwent a number of lines of therapy, again, and not performed at our institution. He had a long story of disease starting in more than 10 years ago. 3 years after the diagnosis, he received bendamustine, only bendamustine for 2 cycles. Again, I say this is not a patient followed by me. I want to underscore that the reason of the treatment was only lymphocyte doubling time, which is something that we always discourage to do. So lymphocyte doubling time might be a criteria in the context of a patient who is becoming anemic or thrombocytopenic or with enlarged lymph nodes. He received only bendamustine without rituximab 2 cycles, then he got a skin rash. He discontinued treatment, and then 2 years later, again, he had lymphocyte doubling time. I don't want even to ask how much was the count at that point. Maybe it was just a small shift, but he has been again treated, unfortunately, with FCR for 4 cycles, and he responded, of course. In May 15, after all this treatment, now the patient really progressed with the need of treatment due to anemia and thrombocytopenia. And again, as we always do, we did a genetic workup. Fish was normal, so none of the 4 aberrations that can be detected by the traditional fish. P53 was still wild type, which is good news after 2 types of chemotherapy. Immunoglobulin gene status unmutated, and as Dr. Peggio already alluded to, we tend not to treat these patients anymore with chemoimmunotherapy, in particular because he already received 2 types of immunochemotherapy, but in particular because the unmutated patients are those who we don't consider anymore patient candidate for immunochemotherapy. Here the number of comorbidities, as you see, in particular coronary heart disease with a stent that was positioned in 6 months before the need of treatment. So the patient, this patient has been indeed enrolled in the ASCENT study, but he has been randomized. Actually, the reason again was, in this case, as I said, was anemia and thrombocytopenia. There was also splenomegaly, 23 centimeters, no bed, so probably the anemia and thrombocytopenia was also due to the splenomegaly because the infiltration in the bone marrow was only 70 to 80%. Usually that does not lead to anemia or thrombocytopenia, where we do see always values above 90%, if not 95% of infiltration. Abdominal lymph node 5.6, which are not the criteria in this case to start treatment, but of course they are nice target to follow due to with the treatment. So as I said, this patient unfortunately he was randomized to the comparator arm in the ASCENT study. I will explain later on more into details. But the comparator arm is a physician choice between either idelalisib, plus rituximab or bendamustine plus rituximab. And all the patients who ended up in the physician choice arm, we always treated them with idelalisib, so we gave the possibility to have access to a novel therapy anyhow. So I started idelalisib, and it was July 2017, 3 months later. He responded very well, as it happens also with the PI3 kinase delta inhibitors. The anemia completely recovered, the thrombocytopenia completely recovered, the splenomegaly recovered at least partially. That's always an issue with all the kinase inhibitors, 16 centimeters, and also the lymph nodes reduced, and they were now a little bit above 2 centimeters. But as it usually happens with idelalisib, after 5 months, he started having neutropenia. So we stopped it for a week, and then we restarted at a reduced dose. That typically works with the idelalisib, starting with a lower dose and then going back again to a higher dose. Almost 1 year after the start of the therapy, he experienced a grade 2 colitis, which needed steroid treatment. So as we always did in the past, we stopped temporarily, we interrupted temporarily idelalisib, and then what we usually do in agreement with the patient, we retry, we re-challenge the patient with idelalisib to see if the patient can get tolerance somehow. And that's what we did. Again, low quantity of, low dose of idelalisib, 100 milligrams 2 times a day with slow steroid tapering. Unfortunately, 6 months later, he had again colitis. So as we usually did, we stopped the treatment forever, permanently, because indeed in that case becomes too risky to go on or to re-challenge even a third time. So we just follow up the patient as it is absolutely recommended, so patients don't need to be treated immediately after stopping any of these drugs due to adverse events. And indeed, this patient in July 2019, he had again disease progression, so we are almost 6 months later, 6-7 months later, again he experienced anemia and thrombocytopenia, and the splenomegaly became again 25 centimeters, again probably suggesting the role in the onset of anemia and thrombocytopenia. Again, the bone marrow biopsy, there was only an infiltration around 80%, and according to the design of the study, of the ASCEND study, the patient could be treated with acalabrutinib monotherapy in the context of the study. So that's what happened, and this is what happened also with acalabrutinib. You can see on the left side in blue the hemoglobin, so it went below 10 grams of hemoglobin, as we saw before, down to 8, but then he recovered nicely up to 14 grams, and the platelets also recovered somehow, but those still remain definitely from the low level of 40,000, and they got up to 100,000, even more, and then they stayed around 80,000. The lymphocyte count, as it happens with all the BTK inhibitor, and is no difference. Acalabrutinib is no different. There is a peak of lymphocytosis shooting from 200,000 to 400,000. This is not a concern. Nobody has to stress or be afraid of that. I heard people who are giving even chemotherapy just to decrease the number of lymphocytes. This is not the case. You just let the lymphocyte go up and then they come down eventually. In this case, the patient stopped the blue arrow. He stopped acalabrutinib because he had hemarthrosis under fondaparinux that was started 3 weeks earlier due to a thrombophlebitis, and so he did this. He started this anticoagulant, and he had the bleeding. So we stopped the acalabrutinib another 3 weeks. So he continued the anticoagulation, and then we stopped that, and then we restarted the red arrow acalabrutinib again. Again, as you see, the number of lymphocytes went up again from 200 to 400, but then eventually the patient remained on acalabrutinib with no other bleeding episode, and as you can see, the number of lymphocytes completely normalized. So with these two cases, I more or less probably said everything I wanted to say about acalabrutinib in the relapsed refractory setting, which is very similar to what John said in the first line setting. So here is the ASCEND study that has been pivotal in the approval of the drug, together with the ELEVATE study in the first line. Relapsed refractory setting, patients were randomized to acalabrutinib alone, or, as I said, physician choice between idelalisib plus rituximab or bendamustine plus rituximab, and the patient relapsing in the second arm could indeed be switched over to the acalabrutinib arm for the benefit of the patient. And this is probably explains why I'm not going to even show to you there is no overall survival difference between the two arms, because all the patients who relapsed in the physician choice have been rescued by acalabrutinib. Patient demographics is just a very busy table. We are not interested. I just wanted to show you that the genetic features. So 3/4, if not 80% of the patient had unmutated immunoglobulin genes. 20% had 15 to 20% had the 17p deletion, and 1/3 complex karyotype. So really suggesting that these are the typical patients with the high-risk genetic features in the relapsed refractory setting, because these are selected somehow. There is a selection bias due to the use of particular immunochemotherapy in the previous lines. This is the PFS, median PFS. This follow-up this is the interim follow-up of 16 months. The median PFS is not being reached. Even in the final analysis at 22 months, so almost 2 years, median PFS has not been reached for acalabrutinib monotherapy. The median PFS was already reached in this initial analysis for both IDELA, bendamustine plus rituximab, the dotted line, the dotted blue line, and IDELA plus rituximab, the solid blue line. Roughly 16, 17 months. For BR, it became eventually to be 18 months with a longer follow-up, which is exactly identical to what we saw in many other trials, and a little bit above 16 months for IDELA plus rituximab. In this case, not because of a lack of efficacy, but because IDELA is usually not well tolerated, as shown by my case also, and so it is discontinued, and therefore the patient cannot benefit long-term by the drug. So the benefit in terms of PFS was visible also in all subgroups, including those with high-risk feature, p53 mutation, immunoglobulin genes. I can show you that more in details with these PFS curves. On the left, the patient with deletion 17p and p53 mutation, where indeed so we see that the two purple lines are patients with and without p53 aberration treated with acalabrutinib, with the blue lines with and without p53 aberration treated with in the control arm, so bendamustine plus rituximab or idelalisib plus rituximab. On the right side, again, purple lines are patients treated with acalabrutinib. The blue lines are those treated with the other two regimens. And in this case, a patient with mutated or unmutated immunoglobulin genes. In terms of safety, I already showed you a couple of cases, and this is confirmed also in the study. There is a lower rate of discontinuation, definitely lower than IDELA plus rituximab, and also lower than bendamustine plus rituximab. In particular, dose reductions were very rarely needed. The adverse events, I don't go into details. You already heard everything from John. Headache is a typical feature. Bleeding, what is interesting in the relapsed refractory setting, we had very few, or at least fewer bleedings compared to all other studies with acalabrutinib. So roughly 1/3 of the patients only had bleeding. They were, as usual, minor bleeding. So if you focus only your attention on the grade 3 column, then you will see that any of the adverse events was indeed in the range of one single digit, with the exception of neutropenia. But we have to remember that these are a relapsed refractory setting, so neutropenia is somehow a part of the long-term sequelae also of the prior treatment. And definitely the neutropenia was lower than with IDELA or with the bendamustine plus rituximab. Other side effects, again, we don't go into details, so we just check at the grade 3 column and to see that the percentage of patients experiencing grade 3 adverse event is really minimal. So if we focus on adverse events of clinical interest, so those that we typically refer to the BTK inhibition, so atrial fibrillation on the left side, hypertension on the right side, you can see that indeed atrial fibrillation, if we consider a 3% background, so due to the age of the patient, there is really a slight increase of another 3% in this patient with a follow-up of almost 2 years. Hypertension, again, the values are very similar, for example, with acalabrutinib or with IDELA, so really suggesting these are probably, again, somehow background values, background noise due to the age of the patient that eventually will develop sooner or later some hypertension. The interesting point here is also that the bleeding was, of course, higher with acalabrutinib compared to IDELA and bendamustine plus rituximab, but we didn't have any major intracranial hemorrhage, which is usually what scares a physician and patient using BTK inhibitors. So just to summarize, also taking into account data shown by John, this is the pooled analysis that we presented at EHA this year. 9 studies with Acalabrutinib monotherapy across multiple B-cell malignancies for over 1,000 patients. And again, the profile is exactly identical as shown by John and by me. So if you look always at the grade 3 column, it's really in the range of 1 or 2%. And if we look in the bottom table that refers to the adverse events of clinical interest, so hemorrhage, cardiac events, or hypertension, again, you do see that the numbers are really low when you look at major hemorrhage or atrial fibrillation or hypertension. With that, I just want to conclude showing the EHA ESMO guidance that will be published next week, October 15. So this is a preview. And really to show, first of all, that chemoimmunotherapy is virtually disappearing from the algorithm, from the scheme. So we might repeat maybe in those who had a long remission duration in first line, but definitely, as you can see at the bottom, repetition of SCR is definitely not recommended anymore. So maybe you can use some BR, but as we know, BR, you can get a 18-month progression-free survival, which is definitely not what we want to promise to our patients. For the rest, is the future and the present looks quite bright for our patients, as long as they can have access to the novel drugs. And as I understood, in India, not everyone has it yet. And hopefully, with the arrival of another BTK inhibitors, Acalabrutinib, it might open up even more the accessibility and the access to the novel drugs. Thank you very much. I also want to thank all the colleagues here who were involved in the ASCEND study. Thank you.